Hello friends, welcome to the NEET 2024 recall session of Radiology by Manipal Medies. Now, before we go ahead and discuss about the individual questions, let us spare a few minutes and discuss about the paper in general. The paper was definitely tough. As far as radiology is concerned, it was a tough paper. Secondly, there were many things about this paper which make it unique. There was paucity of one-liners, there was a lot of clinical data, the questions were lengthy enough, and last but not the least, a very important thing which I have been saying for so long is an extensive integration. In radiology, we found an extensive integration with clinical subjects. There were so many questions in which either a radiograph or any other CT or MR image was given and a clinical question was being asked. So the questions were framed in such a way that you have to have a knowledge of radiology as well as that particular clinical subject to answer that question. So this is a recent trend that we are seeing not only in NICT but also in NEET PG. Now they're deviating from those one-liners and they're going towards more of clinical based questions which require knowledge of radiology along with clinical subjects in great detail. So let's start our discussion with our first question. So here the examiner had given you three different images. In these three different images, examiner had given you an X-ray of the PNS, Waters view, a radiograph and a CT. Now, whenever you get three images from different systems of the body, you know you're dealing with some form of a syndrome. So this was some form of a syndrome that we were perhaps dealing with. So let's have a look at the first image. What we're seeing, look at the maxillary sinus. Both the maxillary sinuses are filled with. It means we are having sinusitis in this patient, and this sinusitis is seen in maxillary sinuses. Let's have a look at the radiograph. Does it look something different? The heart, does it look abnormal? Yes, the heart is now pointing towards the right side. And when the heart points towards the right side, it means we're dealing with dextrocardia. Now, there was another hint in this particular radiograph itself. You can see multiple cystic areas which are located in bilateral lung fields, typically in central parahilar distribution. And to reconfirm it, the other image that was given was an HRCT chest in which you can clearly see these cystically dilated structures in bilateral lung parenchyma which are showing some internal fluid levels. So what are those cystically dilated structures in lung parenchyma which give appearance to this cluster of grapes? We've talked about this before and extensively. This is nothing but this is bronchiectasis, and in this case, because it is more cystic, it is cystic bronchiectasis. We've discussed the same question in our Manipal Medies lectures where the same clinical scenario was given. And I hope now everybody of you know what the diagnosis is. It's Cartagena syndrome. Why is it not cystic fibrosis? It's not cystic fibrosis because in cystic fibrosis you will get pancreatic insufficiency. So examiner is going to give you a CT of pancreas where you're going to find either a calcific pancreatitis or fatty replacement of the pancreas, and in the history also examiner is going to tell you something about the pancreatic insufficiency. The rest of the two ones are definitely not the answers. They want nothing to do with this type of a radiological picture. The most important hint in this question was this dextrocardia. Now see, this type of a question is not just a radiological question. It requires a knowledge of radiology. Without knowledge of radiology, you can't pick up the findings. But it also requires a significant clinical integration of this particular syndrome, that's Cartagena's syndrome. Now, let's come to our next case. Now, this is a complete repeat, the exact repeat of the question which was asked in NICT, only they've reshuffled with the options, the question a bit. So, what do we see here? Because we can see a foreign body and that's shaped like a O, so it must lie in the esophagus. But now examiner just doesn't want to know whether it's lying in the esophagus or trachea. He doesn't even want to know what type of foreign body it is. Last time when it was asked in NICT, it was asked whether it was a coin or was it a button battery. Now, if you see this particular foreign body carefully, we've had an extensive discussion over it. Let me magnify it. You can see that this foreign body is showing two concentric rims. Why is it showing two concentric rims? Because if you see a button battery, it has got beveled margins, while a coin is having perfectly symmetrical anterior and posterior surfaces. So because there are beveled margins of the foreign body, you expect this type of a step off. This is called as step off. And this results in this perfect radiographic appearance, what we call as the double ring sign. Why it's a double ring? Because now we can see two concentric rims, one inside and the other outside. This also has been called as halo sign. Now, these rest of the three signs, we've also dealt with them in detail. Let me show you where do we find them. This is the classical steeple sign, which refers to the narrowing of the upper airway in the form of a steeple. And where do we get it? We get it in cases of croup, laryngotracheobronchitis, which is a self-limiting condition associated with barking cough. What is the second image showing you? In this second image, I hope all of you can see that there is a swollen epiglottis, which is giving rise to a thumb appearance. So this is epiglottitis. We're going to find this thumb sign. And third sign that was given was string sign. Now, string sign is a very versatile sign which you find in number of disorders. But the one in which it has been most extensively studied is in this particular barium study, that is barium meal follow through, where you're going to find the narrowing of the terminal ileum, which is just going to look like a string. So you get string sign in cases of Crohn's disease, but it's not specific. You can get it in cases of ileocecal tuberculosis as well. So that was an easy question. Let's come to question number 3 now. It is one of my favorite questions. Why? Because mediastinal masses is one topic that we had dealt with most precision and in fact most depths in our Manipal Medes lectures. And at that time only, if you remember correctly, I'd shown you the photograph of Mr. Amitabh Bachchan, and I told you that whenever you get a question of myasthenia gravis associated with any mediastinal mass, it is nothing but a thymoma. So in this question, the examiner had given you a hint of myasthenia gravis and ptosis, and he also gave you CT chest. Ideally, these three things are good enough to make a diagnosis. I don't even need to look at the CT chest, because if there is myasthenia gravis, the only mediastinal pathology that you expect with myasthenia gravis is a thymoma. So the answer is pretty straightforward, but we have to look at the CT image as well. So let's look at the CT image and try to grasp what we can make out of it. So this is a cross-sectional CT image. This is the vertebra lying posteriorly. This is anterior. This is right. This is left by convention. We can see the aortic arch. We can also see the SVC. This is the trachea. Why it's trachea? Because it's black. It's jet black. Jet black is something which is air. And just ahead of these vessels, I can see a very well demarcated structure which is showing a soft tissue attenuation. So this is a mass which is lying anterior to the great vessels. So it is a mass which is lying in anterior mediastinum. In anterior mediastinum, we can have 4 major masses. All of them have been given here: thymoma, teratoma, terrible lymphoma, and ectopic thyroid. But the answer in this case again is, because of this clinical history, thymoma. It is definitely not teratoma, because teratoma will show fat. We'll be looking at that image later on. It is unlikely to be lymphoma, because lymphomas are not associated with myasthenia gravis, and this definitely doesn't look like a lymph nodal mass. Ectopic thyroid, again down the list, because this clinical history of myasthenia gravis has made sure that the only diagnosis in this case is thymoma. Now, before I go ahead, I want you to have a look at these two images, very close differentials, both of which were asked in the exam this time. This is the thymoma. We've discussed about it. Now, what do we see here? Again, we can see a mass which is located at the exactly same location as this mass, that is in the anterior mediastinum. But there is something very, very special about this mass. Let me magnify it a bit. So what do we see here? We can see some very hyperdense white colored structures within it, which are just looking like bones. What is that structure which looks white on CT? That is calcification. So this is a mass which is containing calcification. Apart from that, anything else? Look at the internal color of the two masses. This is a gray, homogeneous, while this is more of black or hypodense. It is black or hypodense because it contains what? It contains fat. We've talked about this before also, that fat is something which shows a negative attenuation value. It is dark or black or hypodense on CT. So if you look at the attenuation value, it is going to range somewhere between -40 to -70 Hounsfield units. And what is that particular mass region which contains calcium plus fat, and it is located in the anterior mediastinum? This is nothing else but teratoma. This is how teratomas in the anterior mediastinum are going to look like. And you need to have a pictographic memory of this image as well, because the same question was asked in the shift 2. We'll be talking about that later on. Now, let's come to our question number 4. Here, the examiner had given you a 6 weeks old infant. Anytime examiner gives you a history of a patient who's in his first or second month of life presenting with vomiting and is the projectile vomiting, you know you're dealing with some form of a gastrointestinal pathology. Now, here examiner has given you an ultrasound image. Let's look at the options that we have. We have duodenal atresia, we have annular pancreas, we have microcolon. Duodenal atresia associated with Down syndrome, we know that. It is associated with double bubble. I hope you remember it from our discussion. 3Ds: Down syndrome, dural atresia, and double bubble. And double bubble is going to be seen on X-ray. It can also be seen on antenatal sonography. Annular pancreas cannot be diagnosed on ultrasound. It can show a double bubble on barium studies, and it can be better diagnosed on CT, but ultrasound is not the investigation for it. Microcolon, now this is the option which can easily be eliminated. Why? Because colonic pathologies, whatever they are, they won't be presenting to you with this type of projectile vomiting. Although microcolon is one of those things which is associated with small bowel atrasias, which may present with obstruction and vomiting later in the life, but in case of a microcolon, obviously the examiner is going to give you the image of colon, that is some form of a barium enema or a lower GI enema study. So this is, I'll repeat, like a barium enema study. So let's look at the options. So we are just left with this IHPS, that is CHPS. That is the same term that we use interchangeably. And we know that in IHPS, the investigation of choice is ultrasound. So here, the clinical history of the patient along with the ultrasound image will help us in making a diagnosis of CHPS. Let's have a look at the ultrasound image. What we're seeing, we're seeing a thickening of the pylorus all throughout, which is resulting in luminal compromise of the central pyloric canal. So what should be the thickness? The thickness should be more than 4 mm and the length should be more than 16 mm for CHPS. That we've talked about CHPS, let's quickly discuss the other options as well. So we've talked about duodenal atresia. Duodenal atresia will result in form of two bubbles. So you can see two large gas-filled bubbles. The larger one is the stomach, the smaller one is the duodenum, the first part of the duodenum. And duodenal atresia is something that you can also pick on antenatal sonography. Now this is very important. Antenatal sonography. So if a patient with suspected duodenal atresia comes to you for an ultrasound, you're not going to get a double bubble sign. Only during the antenatal life can you see these two fluid filled bubbles which present nothing but stomach and the duodenum, and these patients are also going to have polyhydramnios. What is this? I hope this is the easiest one for you to diagnose. You can see this is some form of an enema study because we are passing contrast to the rectum. This is the colon, and if you see the colonic loops, all these colonic loops appear to be diffusely thinned out. The caliber is definitely less than 10 mm or less than 1 centimeter. So this type of appearance you see, this is classical picture of microcolon. And where do you find it? You find it in cases of small bowel atrasias, typically the distal small bowel atrasias. And what is the contrast that we give? We usually do not give barium for that. We give a gastrographin for that. So this is how the other options would look like. Now let's come to our next case. Now this was by far an easy question. A middle-aged female becomes unconscious after severe headache, CT head with CT angio. So anytime you have a history of a thunderclap headache, severe headache, and the examiner is giving you a CT angio for it, you know you're dealing with some form of a vascular pathology, typically an aneurysm. So let's have a look at this particular image, what we see. Here in this case, I hope all of you would be able to see that there is this star-shaped hyperdensity which is seen filling all the cisternal spaces, and it is also extending over the cortical sulci. So we know what this star-shaped appearance is. This is classical of subarachnoid hemorrhage. And icing on the cake, the examiner has also given us an image of CT angiography. And if I magnify it, I can see that there is a small aneurysm which is appearing as a bleb or an outpouching from the vessel. It is contrast filled and probably it has ruptured, resulting in this subarachnoid hemorrhage. So the diagnosis here in this case was pretty straightforward. It is SAH with aneurysm. The other options for AVM and dural AVF. So AVM would present as intraparenchymal bleeds, although they can also be associated with SAH, but intraparenchymal bleeds are going to be the primary manifestation. Secondly, you're going to find this bag of worm appearance on CT angiography. You're going to find a mass, I'll repeat, you're going to find a vascular tuft in the brain parenchyma in the cases of AVM. Dural AVFs are also not going to present with isolated SAH. So this image spoke 1,000 words itself. The diagnosis was pretty certain. There's no doubt this is an SAH. Now, before we go ahead, let's have a quick discussion about different types of the extraaxial bleeds. So what do we see here? We can see that there is a biconvex shaped hematoma. Now, this is more of a traumatic thing. It's an EDH. If you see an extraaxial acrocentric shaped hematoma, that is an SDH, which occurs because of trivial trauma, because of rupture of the bridging cortical veins, while EDH occurs because of severe trauma, because of rupture of middle meningeal artery, and it does not cross the sutures, while SDH can cross the sutures. This type of bleed where you find this star-shaped appearance or hyperdensity seen filling the cisterns and the sulcal spaces is seen in SAH. Now comes a difficult question. Actually, this was one of those questions which I think has been asked for the first time. And this is a bit difficult if you look at the images per se, but if you try to eliminate the options, it becomes very easy. So we have a 3-year-old female who is presenting with recurrent chest infections and fever. It means we're dealing with some form of an infective pathology, but since it's a recurrent chest infection, it is a disease which is having a chronic background as well. So she undergoes a chest X-ray and a CT chest, the images of which the examiner had given you. And at the same time, examiner had also given you the antenatal sonography images. Now, this does not make sense. The patient is coming to you at 3 years of age, so you will image the patient at that particular age. But the examiner is also giving you an image of antenatal sonography of the same condition. It means examiner wants to highlight that this is some form of a congenital pathology, because only congenital pathologies you can pick on an antenatal sonography. Infective pathologies are really acquired pathologies. So what are the options do we have? We have lung abscess, we have pyoneumothorax, we have CDH, and we have CPAM. That is congenital pulmonary adenomatoid malformation. Some people also call it as CCAM, congenital cystic adenomatoid malformation. So we are left with two congenital pathologies, that is CDH and CPAM. Why cannot it be lung abscess? Because lung abscess would present as a thick walled cavity with air fluid levels. Now in this case, we don't see any air fluid levels anywhere. If you see the CT image, now in this CT image, again, this is anterior, this is posterior, this is right, this is left. We are seeing again a cystic mass which is located in the right lower lobe. The same thing can be seen on the X-ray as well. But why is it not congenital diaphragmatic hernia? Because here, whatever this thing which is lying in the right lower lobe is not looking like bowel, it is not looking like abdominal contents. Secondly, look at the dome of diaphragm. It is perfectly preserved on the X-ray. So the possibility of CDH is somewhere down the list. And what do we see on this anterior sonography? I know it's very hard for you to interpret. I mean, this is one of the most difficult diagnoses to make, even for radiologists. So as far as undergraduates are concerned, I think this is something which we don't expect you to diagnose. But what do we see here? If you just make a midline like this, then you see here, there's something abnormal. We can see multiple cystic areas which are located towards one side of the fetus. And these cystic areas are also associated with abnormal interspersed echogenic foci, that are linear echogenic foci. So this is again an appearance of CPAM, congenital pulmonary adenomatoid malformation. Let's try to eliminate the options. Even if you don't know about CPAM, let's try to eliminate pyoneumothorax. What will pyoneumothorax present like? Pyoneumothorax means presence of pus and air within the pleural cavity. So we talked about hydropneumothorax. We've also talked about pyoneumothorax in detail in our MEDACE lectures, where we learned that hydropneumothorax would present as an air fluid level. However, here we don't see air fluid level, rather we can see multiple cystic areas. So pyoneumothorax and lung abscess are definitely out of question amongst the two congenital pathologies, because I can see the diaphragm perfectly normally. This is nothing but it is CPAM or CCAM. Now let's come to the next question. A bit twisted question, a bit confusing question, but overall not a very difficult question to answer. An 18-year-old patient presents with low-grade fever, lethargy, pain and swelling in leg. The swelling is warm and tender. So if you read only the first few lines of the question, it seems that we're dealing with some form of an infective pathology. And what is the infective pathology that we talk about in MSK? We're dealing with osteomyelitis. This is the first impression if you will get. But stop yourself a moment, give some rest. Let's read the entire question. Hematological investigations reveal raised ESR again, an icing on the cake. It also suggests that we're dealing with some form of an infective pathology. The X-ray of the patient is done, which shows a sunburst periosteal reaction. Now, we've talked about sunburst periosteal reaction, and this is nothing but a very aggressive reaction, I should say, which is seen in malignant bone tumors. And we've also talked about that sunburst periosteal reaction is not specific for any specific bone tumor. It can be seen in any aggressive malignancy. So what is this now? We can call it osteosarcoma because we've been given a sunburst appearance, because the age of the patient is 18 years. But here is where our radiological image and our knowledge of radiology would come into play. When we look at this particular image, we can see that the epicenter of the disease is located in the diaphysis. And we know that osteosarcoma is not a diaphyseal tumor, it is a metaphyseal tumor. So this makes one thing for sure, that we're dealing with Ewing's sarcoma. And if you see carefully, you can see some lamellated periosteal reaction as well. The most important point to take home from this question is that no particular periosteal reaction is specific for a malignant bone tumor. You can get sunburst periosteal reaction or Codman's triangle in Ewing's sarcoma as well. Now, before we go ahead, let's have a look at few other important bone tumors. This is the one that we've already talked about, where we could see a lamellated periosteal reaction, a permeative lesion located in the diaphysis. This is Ewing sarcoma. This is one of the other spotters, which can again be asked, where you see multiple lytic areas in the skull vault, giving rise to a raindrop appearance. I hope you know what it is. It is multiple myeloma. And look at this third image here. What we are seeing is we are seeing a very aggressively looking bone tumor, which is associated with a cumulus cloud appearance, and it is also associated with a sunburst periosteal reaction. But this lesion is located in the metaphysis. So this is a typical osteosarcoma. It is how osteosarcoma looks like. Important point to remember, we decide the type of bone tumor based upon the location and just not on the basis of periosteal reaction. Next question. Identify the Garbi stage of this disease. Now, the Garbi stage of this disease, I think this is something which is very important, has been asked in all exams in one form or the other, and we have extensively covered it in all our sessions or at middays. So what do we see here? I hope everybody of you is going to recognize what it is. It is a cystic lesion in liver, and we can see some infolded membranes which have detached. So what is this thing called as? It is called as water lily sign, and we are dealing with a case of hydatid cyst. So the examiner did not want to know what is the diagnosis. This time he deviated and he asked what is the Garbi stage of the disease. He didn't even ask the WHO stage. So we've talked about this before in detail. We've narrated the entire story, the chain of events that occurs with the poor hydrated once it gets into the liver. So once the membrane starts detaching, it is stage 2. And if we talk about the WHO, then this is CE3 that gets reversed. So just a quick revision of the various stages of hydatid cyst. So if you find this unilocular cyst with no detached membranes, it is stage 1. If you find this early detachment of membranes, which can be seen as a water lily sign, it is stage 2. If you see a multilocular appearance, as you can see here, this multilocular appearance, it is stage 3 according to Garbi. Stage 4 is the one when there is an amorphous mass without calcifications, without daughter cyst. And if you find this calcification within the hydatid cyst, it is Garbi 5. So this was about Garbi staging, and I hope majority of you would have got it correct, because this is one topic which we had covered extensively and on repeated intervals. Now comes the difficult question. Now, again, I should call it a new sort of a question, but again, if you have basic knowledge of anatomy and a basic common sense, probably you would have been able to make an intelligent guess over it. So there was an elderly male patient who presented with chest pain and hoarseness of voice. So this is written wrongly. It's basically hoarseness of voice. Now, whenever you have an elderly patient coming to you with hoarseness of voice, the first thing that we have to rule out is vocal cord palsy. Why? Because elderly gentlemen can have a lung mass, a nodal mass, which may compress upon one of the laryngeal nerves, more commonly the left recurrent laryngeal nerve, because it is having a longer course. Laryngeal nerve. Okay. Now, what the examiner had shown you, he had given you an angiographic image. Now, whenever the examiner gives you an angiography image, and that too of a chest, he's talking about some form of a vascular pathology. So what are the vascular pathologies that we know of? So we studied about aneurysms, we studied about dissection, and we have also studied about coarctation of aorta. So all these three options were actually given in the question also. Let's have a look at the image. What are we seeing? We're seeing in contrast filled outpouching here, a contrast filled outpouching, which you can appreciate on these volume reconstructed images as well, which we call as VRT images. Now, just using the common sense, can you strike a common channel between recurrent laryngeal nerve involvement and any of those three features? Yes. Anything which can compress upon the left recurrent laryngeal nerve can also cause hoarseness of voice. So can you think coarctation of aorta can compress? Coarctation means what? Stenosis, narrowing of the aorta. It cannot compress. It can narrow the aorta, but it cannot narrow down other structures. Similarly, aortic stenosis was one of the options. Similarly, when there is stenosis of the aorta, how can it affect the recurrent laryngeal nerve? It can't. Then we are left with dissection. Dissection is a pathology which involves the internal lumen of the aorta. So what are you going to get? Either you're going to get an intimal flap or you're going to get a double lumen. We didn't get an intimal flap, we didn't get a double lumen. So dissection was a bit unlikely. So what is that thing which is also having a mass effect which is related to aortic disease? It is an aneurysm. So the most obvious answer was a saccular aneurysm. In this case, you can see it hanging along the wall of the aorta. So it's a saccular aneurysm. But you had to rule out this also, because it is also an aneurysm, but there is a dissection associated with it. In this case, the examiner would have definitely given you a clue towards dissection. Either he would have given you an intimal flap or he would have given you a double lumen. Since nothing of that was provided, so your answer was a secular aneurysm. And if you have an aortic aneurysm which is compressing upon the recurrent laryngeal nerve, leading to vocal cord palsy and hoarseness of voice, is called as Ortner's syndrome. Ortner's syndrome. Now, let's come to the next question. Now, this is a question that I really liked because I had covered PNDT in great detail and I knew that one question is going to be definitely coming from PNDT this time. So, what you have a gravida 5 L4 female with all girls with live issues. She comes to sonography at 20 weeks of gestation. She insists on knowing sex of the baby. This happens very, very commonly, more common than you can think about. I do sonographies day in and day out, and every time I deal with a patient where the mother is going to ask the sex of the baby. So what you should do in such a circumstance? What does PNDT say? First of all, you should do a USG or not. So first three options were do a USG or refuse sonography. Now, if you keep on refusing sonography on these terms, I should tell you 50% of your sonographies will be lost because every other female is going to ask the same thing. Although asking is also an offense, but still you can't refuse it just based upon sonography. So what you can do, you'll have to do the USG, and now you have few options. You can look at the sex of the fetus and tell the patient. You can look at the sex of the fetus and don't tell the patient. And you do not look at the sex of the fetus, nor you tell the patient. What do you think is the correct one? The correct one is this: neither look, sex, or nor tell. In PCP and DT, you do not do sex determination. It doesn't mean that you don't tell the patient. You don't detect the sex of the patient. Even that is a crime. If you've detected, it means you've determined the sex. Whether you tell it or not, that's a different story altogether. But if you've detected the sex, it's a crime. So you do not even see the sex of the patient. And why at 20 weeks of sonography you want to look for congenital anomalies? Because we do TIFA, that is level 2 scans at 20 weeks. So you want to look at congenital anomalies, but in a normal congenital anomaly scan, we don't look at the sex of the fetus. We look at the sex of the fetus only in a very narrow range of disorders like X-linked or sex-linked disorders. But in this case, the answer would have definitely been C. Now let's come to the next case, which is actually the last case of session 1. And this was the bang-on diagnosis. I mean, it was very easy. This was a sagittal image of sonography of the fetus, antenatal sonography. And what are we seeing? We are having a fetus, the brain of which doesn't look normal. Why? Because we don't see any ossification of the skull bones. We can see a dysmorphic structure which is protruding and it is hanging inside the amniotic cavity. So what is this disease? Where the skull vault fails to develop? It's anenchyphly. I don't know about the other options, but that doesn't make a difference because it was one of the easiest ones. Few other points about anenchyphly, we had covered it in detail and I had told you about the different signs. We can get a frog's eye appearance, and one other important thing about anenchyphly that you should remember is that it is the earliest anomaly which can be diagnosed on sonography. Now, let's start with paper 2. Paper 2 was more exhaustive. There were many questions in radiology in paper 2, that is in shift 2. And I should tell you, it was much more difficult as compared to the paper 1. It was more clinically integrated as compared to paper 1. So let's have a look at image question number 1. So this question number 1, to start with, I should say it is a controversial question. Why it is a controversial question? Because you were given an MRCP image. Some people say that this image was given, but I personally feel that this image was the one that was given to you. It was an inverted image. In MRCP, we don't give inverted image, but this was the image that I presume that was probably given to you. In this case, if this image was given and you see a dilated CBD, the diagnosis is pretty certain. We've talked about this in a number of times. This is nothing but a colloquial cyst. But the examiner didn't give you a colloquial cyst. The examiner perhaps gave you this, where you could see there was dilatation of the proximal CHD. The right hepatic duct is dilated, the left hepatic duct is dilated, and then you don't see the CBD for a long length. You see there is a stricturing type of a CBD located throughout it. And so this type of an appearance is most likely that of cholangiocarcinoma. Now, the other two options that were given, gallbladder carcinoma is definitely out because for gallbladder carcinoma, we don't do MRCP. Gallstone, look at the gallbladder, it is well seen. Look at the gallbladder, it's well seen. The gallstone is also out of question. Now, there are two probabilities for this question, and it's still a controversial question. It can either be a colloquial cyst if this type of image was given, but I feel personally that the correct answer in this case was cholangiocarcinoma because this type of image was given, although again it's not the correct image to be given, but this is how things work. Controversial questions always are a part of the exam spectrum. Now, question number 2. A 10-year child presents with knee pain after road traffic accident. Physical and radiological evaluation reveals injury to the mark structure. Now, this was an easy question. I'll call it an easy question. It is also integrated to the orthopedics, to the anatomy, you can say. And what do we see here? This is femur, this is tibia, this is patella, and you see something wrong here. Even if you don't know anything about the disease in question, you still know that this is something which is located anterior to tibia along the upper aspect of tibia. So what is that particular thing which is located anterior to the upper aspect of tibia? That we know is tibial tuberosity. And here what we're finding some form of avulsion of the tibial tuberosity. So what is the diagnosis in this case? Although it was not asked, but the diagnosis in this case is Osgood-Schlatter disease. Osgood-Schlatter disease. We don't even need to know the other options. I mean, this is one of the easiest questions that you can think around. Question number 3. Now, this was an interesting question. In this case, the examiner wanted you to identify the investigation that he had shown, and this investigation looked like an X-ray. If you see carefully, it is looking like an X-ray of the cervical spine. You can see the cervical spine, so it's an X-ray of neck or the cervical spine. But there is something different. Apart from the radiograph, we can see that there is some opacification which is present just anterior to the vertebrae. What is that particular investigation, which is an X-ray based investigation, but you add some contrast over it, which can be either given orally or rectally? Yes, it's a barium based investigation. So it's a barium based investigation. So what are the barium based investigations you know of? You know of barium swallow, you know of barium meal, you know of barium meal follow through, and you know of barium enema. Since it is neck, and what is the part of the gut, the part of the GIT which is present in the neck which transmits food from the mouth up to the stomach? That's the esophagus. So in this case, we are opacifying nothing but the esophagus, and so the answer in this case is barium swallow. Now, this is a confusing option, fluoroscopy. Fluoroscopy is actually a technique which we use. It's more of a dynamic technique in which you see things on a live basis. Barium swallow is also done under fluoroscopic guidance. So fluoroscopy can be one of the answers, but when you have to choose one out of the two, because the investigation is being asked, I'll still put my money on barium swallow. Look at the other two options: X-ray of the patient with acid stricture, X-ray of the patient with alkali stricture. First of all, it is not just an X-ray. It is an X-ray, but it is complemented with a barium study. So this part is definitely incorrect. And if you have an X-ray of the patient with acid or alkali strictures, that are going to occur in the esophagus. So you're going to find some narrowing in the esophagus. You're going to find some pooling of contrast, some dilatation upstream to the level of narrowing. We find nothing like that in this particular case. We can see a smooth passage of barium. Barium column is very well seen in the upper esophagus. One more important thing to remember is that whenever we talk about barium swallow, we are just used to looking at those images of frontal projections in which we can see the esophagus being outlined throughout its length up to the G junction. No, it's not true. In barium swallow, we also look at the pharynx, we also look at the vallicula, at the upper esophagus. So this upper esophagus is opacified not only on AP projections, but also on lateral projections, and this is what the examiner had shown you. Coming on to our next question. Now, this question is another one of those questions which was closely integrated to ophthalmology. But if you would have studied, if you would have remembered what we talked about in Meday's lectures, I think this would have been a cakewalk for you, because we had also talked about the clinical features of these particular lesions. What do we see here? We can see that there is a suprasellar mass which is giving rise to a figure of 8 appearance. Figure of 8 appearance, or you can also call it as snowman appearance. And it is appearing very bright. Why? Because it is enhancing. So what is that particular lesion which is present in suprasellar location, gives a figure of 8 and is associated with visual field effects in adults? That is pituitary macroadenoma. And I'm very happy that this question came, because we have talked about sellar and suprasellar masses in great detail. So both these masses, the other mass we're going to talk about in the later section, were asked in the exam this time. And what are the visual field effects? I think the ophthalmology faculty will be covering it in greater detail, but we've already talked about it. It is bitemporal hemianopia. We've talked about it in our lectures as well. So I think this was an easy one. Now let's come to the other counterpart of the question. Another, again, suprasellar mass being asked in the same exam. But now what the examiner did, examiner reduced the age. Now this was a relatively young aged male, 15-year-old male with a delayed puberty and again visual field defects. MRI of the brain shows a suprasellar mass lesion. So examiner has made your life a bit easier. He's telling you that there is a suprasellar mass lesion which is showing internal fluid levels and surgical excision shows motor oil fluid. Even if you don't know anything about this, what is that particular mass which is going to show you an internal fluid level? The mass which is cystic. Cystic. Solid mass cannot show fluid levels. Only cystic mass can show fluid levels. So what is that cystic mass seen in cellular supracellular location in a pediatric patient? It is nothing but craniopharyngioma. We talked about C's, if you remember that craniopharyngioma is associated with a lot of C's, one of which was cystic appearance. So on this image where you can see that there is a heterogeneous mass which is again showing some hyper intensities. Why? Because it is enhancing on post contrast study. So the answer in this case is typically craniopharyngioma. This is more of the clinical integration of motor oil fluid. So this again points to the diagnosis being craniopharyngioma. GBM, it's not the site, and GBM is typically seen in middle-aged elderly patients and it is not typically supracellular location. Meningioma, it is not cystic, although it can be present in the cellular and supracellular location, but it is more solid and is exuberantly enhancing, and it is not going to be seen at this particular age and is not going to show internal fluid or motor oil fluid. Similarly, retinoblastoma, although it's a tumor which is seen in the orbits, but triradiate retinoblastoma can be seen in the pineal region as well. So this is again not looking like retinoblastoma. It's located in the cellular supracellular region and the eyes of the patient are normal, and the age is not also in favor of retinoblastoma. Now coming on to the next question, again something which we've discussed it in great detail, the anatomy. So what are the other structures labeled? This structure was labeled as 1, this structure was labeled as 2, this structure was labeled as 3, this structure was labeled as 4. So what do we see here? We can see two structures which are hyperdense. And why will they be hyperdense? Because there is contrast in them. So they have vessels. So this is one vessel, this is the other vessel. This vessel is arching anterior to posterior. So this is aortic arch, and the rightmost vessel we've talked about can be nothing but SVC. The one which is present towards the far right is always SVC. Now look at this structure. This structure is jet black. Why? Because it is filled with air. So what is that jet black structure, which is tubular structure filled with air, located in the chest anterior to the vertebra, which is transmitting air through it? Yes, you're right. It is trachea. And here this structure which is marked as 4 was a collapsed structure which may contain air. So what do you think would be collapsed? A tube which is going to transmit something only intermittently, but we have to breathe in every time. So trachea would contain air at all locations, but if you see another tubular structure which may contain fluid which is seen in collapsed state, then it is nothing but esophagus. It will dilate itself only when it has to allow food to pass through it. So looking at the options, there's only one option where you would find this particular combination. 1 is SVC, 2 aortic arch, 3 trachea, and 4 esophagus. I hope majority of you would have got it correct because this is something that we had discussed in great detail. Now, another question which was significantly integrated with medicine. A patient with pancreatitis complains of sudden onset shortness of breath and the X-ray of the patient was shown. Now this X-ray of the patient shows you fluffy opacities which are interspersed all throughout the lung parenchyma. Now when you see such type of opacities, your first thing that comes to your mind could be a cardiogenic pulmonary edema. But we had talked about cardiogenic pulmonary edema presenting in form of bat wing or parahilar appearance. And most important thing which is given in this case is this history of pancreatitis. In cases of pancreatitis, you don't develop a patient to develop a congestive cardiac failure. So cardiogenic pulmonary edema is definitely not one of the options. And what else can be? In pancreatitis, we definitely can have a disease which is called as ARDS. ARDS is something which is interchangeably used with non-cardiogenic pulmonary edema. Here what we are looking at, we can look at these opacities which are interspersed randomly in bilateral lung fields. They're not located in the central parahilar distribution. This is most likely a case of ARDS or non-cardiogenic pulmonary edema. In pulmonary thromboembolism, we can get a number of X-ray signs, but we definitely are not going to find this type of a diffuse opacification in the lung parenchyma. There is Palla sign, there is Westermarck sign, which we already talked about, which refer to focal oligemia or dilatation of the pulmonary arteries. But we don't get this type of a pattern in which you can see this entire lung parenchyma bilaterally would show diffuse opacification. Coming on to the next question. Now, this is one of those questions which we have discussed previously also, so I'll be very quick with it. CT image of the patient was shown, and there was a lesion which was mentioned which was having a negative attenuation value. So you don't even need to look at this particular lesion. Whenever you find a lesion which is showing a negative attenuation value, you mean fat within it. And when we talk about anterior mediastinal mass which contains fat plus calcifications, we have only one diagnosis, and that diagnosis is teratoma. Teratoma. But here the examiner didn't ask you this question. He changed the options a bit. Was it a hydrated cyst? No, it cannot be hydrated cyst. Why? Because hydrated cyst will not contain fat. Similarly, thrombotic aneurysm, it will also not contain fat. Mass compressing the vessels, it could have been one of the answers, but if you see carefully, this is ascending aorta, this is descending aorta, this is the left pulmonary artery, this is SVC. So this mass is located in the anterior mediastinum. It is not causing significant mass effect on the vessels. It cannot compress the vessels. It can displace it, but even in this case, it is not compressing the vessels. So it is also out of the question. The answer right now is a very simple one, anterior mediastinal mass with calcification and fat. If you would have got this minus 62 HU correctly, then there is only one option which mentions fat, and it is the right answer. Now this one is a bit tough one. Identify the diagnosis in this image. There was no history given. There was just a, or you can say a one-liner question. What do we see here? Let's look at all the options and then we'll try to eliminate them. Start from the D one. It is the easiest one. Vein of Galen. We've talked about this in great detail. Vein of Galen malformation will be seen somewhere here, and then the examiner is going to give you a history of some bruit which would be felt, or he would give you a history of some form of a hemodynamic alterations in the body. It doesn't look like a vein of Galen malformation. Dandy-Walker, again we've discussed this in great detail. Dandy-Walker malformation is associated with posterior fossa cyst, and the posterior fossa is enlarged in such cases. The posterior fossa looks normal sized. I don't see any cyst. So again, it's gonna be out of question. Does it look like corpus callosum agenesis? Definitely not. I think it's the easiest to eliminate. You can see the corpus callosum very well outlined seen. So corpus callosum is not agenetic. So we just left with one option, Arnold-Chiari 1 malformation. And why is it Arnold-Chiari 1 malformation? I want you to have a look at the cerebellar tonsils. Let me magnify this image a bit. So what do you see here? This is the clivus, this is the occiput. We draw a line which is called as Bayesian-Opisthian line. And if you see carefully, you can see that a part of the cerebellar tonsils is herniating inferiorly below this line into the spinal canal. So this is a characteristic of Arnold-Chiari 1 malformation, in which you will find an inferior descent of the cerebellar tonsils below the Bayesian-Opisthian line. Even if you don't know anything about it, you can easily eliminate the other three options in order to clinch the answer and the diagnosis in this case. Now comes the 10th question. Now this is one of those questions which we dealt with in great detail. I hope everybody of you would have got it correct. What is the diagnosis on this plain X-ray abdomen? What do we see? We can see all these chunky calcifications which are present in the epigastric region. They are present on the right side, left side, and in the midline also. They're crossing the midline. If I ask you which of that particular organ in the body is located at this level which can get calcified and can give rise to this type of an appearance, we have pancreas, which is one of the organs which is located in the midline and can result in this type of appearance because there is a disease that we know, chronic calcific pancreatitis, which is associated with calcifications within the ducts, that is interductal calculi, as well as in the parenchyma. So it can be a case of chronic pancreatitis. Let's look at the other options. Fecalith, no, it doesn't look like that. Fecalith are basically small structures which are located within the lumen of the bowel. They occur because of some distal bowel obstruction. You don't see any signs of bowel obstruction here. It doesn't look like a fecalith at all. Calcified lymph nodes? No. Calcified lymph nodes will be present here, there, everywhere. They will be present more in the para-aortic region. But this lesion is actually going far beyond the level of the retroperitoneum. It's going up to the level of the splenic hilum or the pancreatic tail lesion. So again, that's out of question. Horseshoe kidney with calculi definitely can't be horseshoe kidney because horseshoe kidneys are located slightly inferiorly. If you remember our discussion, the descent of the horseshoe kidney is stopped at the level of L3 by the inferior mesenteric artery. So they're located more inferiorly. So you can get horseshoe kidney calculi somewhere here, but it is located very high up. These calcifications are located in the epigastric region. So the answer in this case is definitely going to be a chronic calcific pancreatitis. And we covered this in great detail. I hope majority of you would have got it correct. Comes the next question. A 35-year-old patient presents with fever, no meningeal signs, MRI of the brain is done and diffusion weighted imaging is also shown. Again, this is one of those questions that we had dealt in detail. And let's first dissect the images to see what we're dealing with. So what is this image? Because CSF is black, it is a T1 weighted image. And because we can see some bright linear structures here, there, everywhere, which are looking like vessels, it means this is a contrast enhanced T1 weighted sequence. So you give in contrast. So what do we see? We can see that there is a lesion which is showing peripheral rim enhancement, and the same lesion on diffusion weighted imaging. The examiner had made your life a bit easier by already telling the name of the sequence. We can see it is restricting, it is bright. So what are the things that restrict? The things which are filled with tenacious fluid, like we've talked about that, like abscesses, like epidermoid cyst, and also infarct. So let's look at the option. Abscess is definitely my primary option, my favorite option that I would keep. But glioma can be one of the differentials. Glioma can also present with cystic areas, necrosis, and that can also result in peripheral enhancement and central diffusion restriction. But will gliomas present with fever? This is the reason why I'm saying radiology was very, very closely integrated to medicine this time. If you would have read this question, if you would have looked at just the image, you can have a lot of differentials. You need a knowledge of medicine, you need a knowledge of radiology to come to a conclusive diagnosis in this case. So gliomas are not going to present with fever. Toxoplasma doesn't look like one, usually it does not restrict on diffusion, and then it presents with the eccentric target sign, which is not seen. Tuberculoma again can be one of the possibilities. Tuberculomas can present in this manner in form of peripheral ring enhancement, but tuberculomas are small ring enhancing lesions. They are much smaller ring enhancing lesions. So this is not a tuberculoma. The answer in this case is pretty straightforward. It's an abscess. Now, the next question, very similar looking question. Here, the examiner had changed the age, a young patient with seizures. Now, clinical history plays a very important role. Remember, when we were talking about CNS infections, I had highlighted this point many a times that whenever the history of seizures is given without fever, you probably are not talking about tuberculosis. Rather, you're talking about NCC if you find a ring enhancing lesion. Similarly, here we can see a ring enhancing lesion. Now, the patient is on an MRI table and the examiner wants to know what is the next best step in management and to confirm the diagnosis. So the options are B scan of the orbit, CB NAT for CSF, MR spectro, and PET scan. Some of the students also said that in the question it was written that the LP findings were normal. In any case, let's have a look at the options. B scan of the orbits, sometimes you can pick some orbital cystic circles, but again, not definitive. PET scan, again, it is going to tell you the disease activity throughout body, but it cannot tell you the diagnosis. So again, it's of no use. Then we have CB NAT for CSF. It makes sense. I mean, if you can get CB NAT positive, then you can say that it is probably tubercular. But if you get it negative, again, there's no meaning to that. The patient is on an MRI table. The best investigation that you can do right now, the most non-invasive investigation is an MR spectral. If you see a lipid peak within it, you know it's tuberculosis. And if you don't see, it is NCC. Both of these two options are again very closely related and confusing. But remember, one of these options is more invasive. This option is something which is non-invasive. Patient is lying on the MRI machine. You can do an MR spectro, and the outcome of both the investigations is similar. So this option would outweigh the other options. I'll give more stress, more weight to this option. Probably this is going to be the correct answer. Now, another question where there was a lot of clinical integration with medicine. A patient presents with chest pain, BP is 130/80, respiratory rate is almost normal, pulse rate is increased. Now, echocardiography shows collapse of right atrium and diastole, which means we're dealing with some form of pericardial effusion. The X-ray image was given and you can typically see that the cardiothoracic ratio is increased, it's enlarged. We're dealing with a case of pericardial effusion. And what is the sign that we see? We can see typical water bottle heart or money bag heart, which we've discussed many times. And this is actually one of the very hot favorite question of examiners. I don't know why there are so many questions of pericardial effusion these days. So the options that were given were drainage of pericardial fluid, diuretics to reduce volume overload. Diuretics would be given in the case of CHF. It does not look like CHF. So CHF is down the list. NSAIDs and steroids to reduce inflammation. We're not dealing with an inflammatory pathology. So the answer is pretty straightforward. It is drainage of pericardial fluid. Next question. A patient presents with high-grade fever ranging from 101 to 103 degrees, purulent productive sputum. Now, if these two options are given and an X-ray chest is given, you know you're dealing with an infective pathology. When there is purulent sputum, you know it's some form of an infection, some form of an anaerobic infection, an immunocompromised patient, perhaps an alcoholic patient. And the chest X-ray is showing what? It is showing a thick walled cavity with internal fluid levels. We've discussed this many times. I hope everybody of you knows what it is. We're dealing with a lung abscess. Now, why is it not empyema? Empyema is going to be lying outside the lung parenchyma. It is going to be located in the pleural space and is not going to show air fluid levels until unless it is secondarily infected with some air containing bacteria. That is going to result in pneumothorax, not empyema. Pneumatocoel can present as thin-walled cystic lesions within the lung parenchyma, but then again, they won't show this air fluid level. Similar as with pneumatic bullae, they're going to be located in the upper lobes, and we don't expect pneumatic bullae to show these air fluid levels. So I think this was pretty straightforward question. We have covered this extensively in our lectures, so I hope everybody of you would have got it correct. Another question, we've covered this extensively also. Now in this case, the examiner had given you a CT image, and I think this was again a very easy question. Why? Because we can clearly see the diagnosis hidden. Look at the posterior margin of the vertebrae, it's all normal till here. But what is happening here? This vertebra, that is L5, is showing anterior translation over S1. So it can be called as enterolisthesis of L5 or retrolisthesis of S1, whatever you feel like. So the examiner didn't go into much of confusion. He used the term spondylolisthesis, which is the correct answer in this case. Let's look at the other options. Metastatic collapse, I don't see any collapse. The vertebra are very well demarcated, very well outlined. Renal osteodystrophy, I don't see any rugged jersey spinotype of an appearance, so it's out of question again. Tuberculosis, again, no collapse. I don't see any collection, I don't see any inflammation. It is not the right answer. Spondylolisthesis is the easiest one. Now, question number 16. Regarding esophageal foreign bodies, what is correct? So, when the examiner had already given you a hint that it's an esophageal foreign body, why did he give you this particular image? He gave you this particular image because it was very important in eliminating the options. First option, right main bronchus is one of the sites of constriction. No, it's not the site of constriction. You can even see this foreign body located very high up. It is not located in the region of the right main bronchus. In fact, left main bronchus is the site of constriction. Can't cause mediastinitis, it is completely wrong. Once the foreign body goes on, erodes from the esophagus, it can cause mediastinitis, and button batteries are more prone to cause mediastinitis as compared to the normal coins. We've talked about this. Commonly seen in adults, perfectly wrong. Foreign bodies are seen in children. Adults are sane enough not to put such things in their mouth. Most common site of infection is cricopharyngeus. Yes, that's correct. You can even see that if you just recall your images of foreign bodies, all the foreign bodies in the esophagus were located here. You won't have seen any foreign body here, anywhere. Why? Because this is the most common site of impaction. Cricopharyngeus is the narrowest part. So even if you don't know much about the options, take the help from this image. So every time you get an image, every time examiner is giving you something, there is a reason why he's giving you this. So in this particular case, just because he gave you this image, it helped you in ruling out a few of options. Now, a difficult one. Identify the condition shown in this CT image. So first of all, let's dissect this image. What is this CT image? I can see the vertebra. I can see kidney on one side. So it means it's a CT image of abdomen. On the contralateral side, where there should ideally be a kidney, I don't see any kidney. Rather, I can see a large cystic structure all throughout. And this cystic structure is very homogeneous because it contains fluid. So it means we're dealing with some form of a renal pathology which has accumulated fluid in itself. What are the options that we're having? First of all, we'll go from D to A. Renal cell carcinoma doesn't look like one. A renal cell carcinoma won't be cystic, won't contain fluid. It would be more solid, it would be more enhancing. So renal cell carcinoma is out of the list. Renal cyst and polycystic kidneys, yes, definitely. These two possibilities can still exist. But I still don't give much weightage to it because these cystic areas are communicating with the larger cystic areas, which is likely to represent the renal pelvis. So both of these options are slightly down the list. Peugeot stenosis would be the first probability. Why? Because I can see a large disproportionate structure as compared to the calcial system seen here. In Peugeot stenosis, we've talked about this before, you're going to get a significantly dilated renal pelvis along with dilated calcial system, and these calyxes would be communicating. This is most important. In case of polycystic kidney disease and renal cysts, these cysts won't be communicating. Here you can see communication between the cysts and the dilated renal pelvis. So this is a classical example of Peugeot stenosis. Next question. A TVS scan of a patient on day 2 of cycle revealed a lesion in adnexa showing incomplete septa and cogwheel appearance. I should say it's a copy to copy paste question which we already discussed in our lectures. I had talked about this incomplete septa sign and cogwheel appearance. So you can see here that there is a cystic or a black colored or an anechoic lesion where there is a wall or a septa which is incomplete. Why do you have incomplete septa? We have an incomplete septa because many a times these tubular structures can get infolded. So if this infolding occurs, it will result in formation of an partial septa type of an appearance. And I already told you that whenever you see this incomplete septa, you're dealing with some form of a tubal pathology. That is, the fallopian tube is diseased in this case. And what is this fallopian tube containing? You can see it's containing all black or anechoic contents. And what is black or anechoic? It is water. So this tube is filled with water. So the answer in this case is definitely going to be hydrosalpinx. Had it been a cyst, any form of cyst, hemorrhagic or endometriotic or follicular cyst, in those cases, you won't find this incomplete septa, you won't find this tubular appearance. And this cogwheel appearance and incomplete septa are actually diagnostic hallmarks of hydrosalpinx, which we had already discussed in great detail when we were talking about gynecological pathologies. Now, this is one of the tough questions, I should say, from the point of view of radiology. But again, if you integrate it with ENT, it becomes easy. The question is long. A female in her mid-40s presents with pulsatil tinnitus and hearing loss. And examination, a reddish blue mass is seen behind the promontory of tympanic membrane. Now, this is the clinching word, a reddish blue mass. If you ever see this reddish blue mass, which is seen through the tympanic membrane, you know you're dealing with glomus. Now, the examiner had given you a CT image where you can see a faint lesion which is located here, a polypoidal lesion which is located in the middle ear cavity. Again, a very difficult diagnosis, not only for you, but also for radiologists. I should confess that once upon a time, even I misdiagnosed this case. I saw this type of a lesion and I reported it as cholesteatoma. Then the ENT guy called me up. He said that I can see some reddish hue through it. Can it be glomus? I said, yes, it can be. We should get an MRI done. And on the MRI, it was diagnosed to be a glomus tumor. Now, when you have glomus tumor, there are two other options that we have been provided with: glomus jugular and glomus tympanicum. Jugular is going to be present near the jugular foramen, while this is present in the region of the tympanic membrane. So it has to be glomus tympanicum. The correct answer in this case was glomus tympanicum. Next question, a very long question. 35-year-old female nulliparous patient. 35-year-old and still nulliparous means there is some infertility cooking in. Then what she has, dull aching pain in lower abdomen, which is aggravated during menstrual cycles, means we're dealing with dysmenorrhea. Sonography shows a heterogeneous mass in right head nexa. MRI shows a 5 by 4 centimeter mass in right ovary, showing hyperintense signal on T1, no fat suppression, and T2 shows low signal with dark shading. This is another one of those questions which we had talked about in great detail when we were talking about gynecological imaging. So, what are the important key points? First is this infertility. Second is this pain during menstrual cycle, that is dysmenorrhea thing. And the most important clincher in this case is this T2 low signal. I hope you remember the classical signs that we talked about in endometriosis was T2 shading sign, T2 shading sign, which is repeated in the same form in this question. Now, what does endometriotic cyst contain? It contains blood products, and blood products are going to be appearing hyperintense on T1 weighted images. This is what the examiner has also given. And what is the other thing which can appear hyperintense on T1? That is fat. And what is that ovarian lesion which contains fat? Dermoid. But if you do a fat saturation, it means you saturate the fat, you remove the fat, then that particular lesion is going to lose its signal. But here it is being said that there is no loss of signal on fat sat images. It means the lesion does not contain fat. So dermoid cyst is out of question. Similarly, ovarian cancer or paraovarian cysts are also out of question, typically because of this radiological appearance and the clinical history that the examiner has given you. This question again was covered in detail in our middays lectures. Now, our last question from shift 2, the easiest one. A 76-year-old elderly patient. Again, the keywords are elderly patient, antihypertensive for previous MI, he is taking aspirin, trivial trauma, and NCCT head of the patient is done. This confusional state is also one of the keywords. So, if you get all this and you get this type of a CT with you, where you can see that there is a crescentric isodensity or hypodensity which is lying over the right frontoparietal convexity, frankly crossing the sutures, you know you're dealing with some form of a subdural pathology, subdural pathology. So it's not SAH, we looked at SAH, we looked at EDH, and this is definitely not a normal study. Had it been a normal study, examiner would have never asked you this question. So it's not a normal study. Now, either it can be subacute SDH or chronic SDH, because chronic SDH also is going to look like this fluid. It will depend upon the chronicity of the disease. In this case, the examiner gave you a history of 3 weeks of the time duration for the injury. So with this, we finish our exhaustive discussion on the questions that were asked in radiology. I hope this discussion was a fruitful one, and I also hope you got majority of them correct. All the best for your results.